Welcome everyone to today's webinar, hosted by Aspire Respiratory Products and entitled The Role of Respiratory Muscle Weakness in Long COVID Patients, a Crucial Part of the Jigsaw. This webinar will be presented by Dr. Mark Faghy. Dr. Mark Faghy is a professor of clinical exercise science at the University of Derby in the UK, and his work focuses on the pathophysiology and rehabilitation of long COVID. Building on his background in chronic respiratory research, he now leads an international, award-winning research team dedicated to advancing mechanistic understanding and developing effective rehabilitation strategies. Central to his approach is ensuring patients are active partners in the design, development, and delivery of research and care, which aligns strongly with our mission at Aspire. Thank you so much for being here, Dr. Faghy. We look forward to learning from you. We'll ask that everybody in the audience kindly hold their questions until the Q&A session at the end. This presentation will be recorded and available for later viewing on the healthcare professional side of our website, which is emst150.com, and I will hand over the stage to you.
Thank you, Jenny. Thank you for that very kind introduction. Really appreciate it, and appreciate the opportunity to come and talk about a topic that I'm really passionate about. So my slides are hopefully just on the way through the ether. I am joining from a hotel in Canada. I've just at a conference where I've been talking about the pathophysiology of long COVID over the last couple of days, and the conference finished this afternoon, and I rushed straight back so that we could do this talk this evening. So thank you, Jenny and Aspire, for having me. And essentially what I'm going to do is talk through the kind of the role and the opportunity that respiratory muscle training can have in addressing some of the important pathologies of long COVID, but also giving some insight and kind of awareness of what long COVID is. But first, I think it's important to kind of set myself a bit of a scene for who I am and my kind of background and how I ended up doing the research that we're doing. It's a question that I get asked very frequently as a researcher. So my career actually started as an applied sport and exercise physiologist, sports scientist, working in the applied world. I've been incredibly lucky to travel the world working in elite sport, professional sport, assisting athletes on their journey of achieving, high performance, trying to find those kind of 1% that make the difference between podiums and finals in Olympics and various different sports. So very well traveled in that scene, and kind of really enjoyed that part of my career. But kind of, at a time in my career where I was looking for another opportunity, my old mentor from university was in touch and said, look, I'm looking at a PhD, looking at the limitations of the respiratory system in occupational settings with military people. Would you be interested in that? And I kind of was like, well, I don't really know. I don't really know much about it, if I'm honest. And he was like, well, you spent the last 5 years looking for 1%. 1% in, occupational health settings is actually, much bigger as an outcome. And probably at that point, it really kind of tuned into me and was like, okay, so did the PhD in occupational physiology, military roles, but then very quickly, into the PhD through an internal talk I did at the University of Derby. I had this opportunity to present to some clinicians, and he was like, well, you're looking at making the respiratory system better. You're understanding what the limitations are. Now you're trying to improve it. And that should help my patients. And I was kind of like, okay, hang on a minute. This is a whole new world for me. But what happened on the back of that, it actually opened, multiple years of opportunities of working in acute medical settings with people who had respiratory infections or chronic respiratory conditions, to try and understand the implications of what this means for a patient. And also, finding ways to develop interventions that can support people through recovery. So up until kind of the middle part of 2019, we completed a series of investigations looking at the mechanisms, the pathophysiology, the interventions, but also the lived experience to try and find ways that we could help in that process. And we wrote a multiple £1 million programme grant, which we submitted to the National Health Service in England in late 2019. It got quite far through the process, but the money was actually redistributed to the front line of the COVID pandemic very, very quickly, and rightly so as well. So we never know if we would have got funded, but we strongly believe that there's a good opportunity, and we'll work with that. Obviously, the funding was redirected to the front line, which is where it needed to go. But very early on, that created an opportunity for us to actually implement some of the work around, patients who were being admitted to hospital settings, but not able upon discharge, actually making that recovery. So very quickly and early in the pandemic, we saw patients coming back to hospital saying, I'm not feeling any better, I'm not getting better, I'm feeling worse than I was when I was in hospital. And we was kind of like, okay, what is it that we're looking at? So I'm leading an international research team at the moment, trying to understand the pathophysiology of long COVID, learning that from that kind of, underpinning physiology of how the body works, the intricacies of the multi-system presentation, how one system or a dysfunction in one system can affect the rest of the systems, and how we can better understand it. And one of my philosophies for research is the only way we can truly affect is if we truly understand. So, we're working very hard to try and understand, how we can affect, the kind of the patient presentation that we're seeing, and very lucky in the opportunities that we've had to work on a global stage. That's why I'm in Canada at the moment, to kind of share this knowledge and understanding. And one of my philosophies that I embed within the group is that we're heavily involved with the patients. They dictate our research journey, their research story. We ask the questions that matter to them, but we're truly collaborative and we share everything and anything. We're not the owners or anything. We're not egotistical in anything. We share everything if it can help and it can be beneficial. So to any of the people who are listening or are interested in collaborating, we're more than happy to have conversations. Essentially, we need to help people. We have an opportunity, the front line of the kind of the pandemic, and supporting people and providing those interventions. So that's the context of me. But what I want to do for the next few moments is just share the context around what long COVID is. Now, I don't know the kind of the knowledge and the awareness of what in the audience in terms of what long COVID is. So I think it's really important just to kind of shed some light on long COVID, what that is as a condition, to help raise the knowledge and the awareness of it, but also to kind of set the scene for where we're going in terms of the role that respiratory muscle training can play. So the WHO defines long COVID as a continuation or development of symptoms that is around that 3 month following acute infection. And the symptoms last and persist and can't be explained by another clinical explanation. Now, there's lots of different variations on the definitions by multiple agencies around the world, but essentially it's that continuation or development of symptoms following an acute infection, and are quite prominent. And what we know essentially affects currently around 65 million people worldwide. It's actually likely to be many more than that because of the kind of the reduction in testing and reporting methods that are out there. There are some literature that suggests it actually could be up to 400 million people per year. And what we're seeing is year-on-year increases in diagnosis as well, driven by continued infection with acute COVID-19. We know that there's multiple pathologies. They don't just work in isolation, they actually interact with each other. What we're trying to do is to understand which are the dominant pathologies and how we can implement interventions to mitigate against those. And as a condition specifically, it's very broad in its presentation. So it can, develop from a mild persistent condition to something that's completely disabled. And in the UK at the moment, there's a suggestion that there's 400,000 people who have been permanently disabled as a result of a COVID infection. So the real need for us to find ways that we can help these people is huge, because it has a massive impact on quality of life and functional status. We see people who were active and running marathons who are unable to walk. We see people who had manual physical jobs who are unable to work. It really does have a broad debilitating impact on people's lives. And what complicates it is that there isn't a single symptom presentation that allows us to say this is the challenge that we have. To date, there's well over 200 symptoms that have been documented, and some of those symptoms are more prominent, so things like fatigue, brain fog, very, very widely reported. But there's also some really complex symptom profiles that are underneath that are kind of less common, but also heavily impacting the quality of life, functional status. And the challenge with the symptoms is they fluctuate. They are not consistent. So you could see a patient today, Tuesday, and you could see them tomorrow, which will be Wednesday, and you might be looking at a completely different person. And those changes often happen with very little notice. And we're going to talk a little bit about that through the back end of the presentation as well. Now, it has been documented that some people do show improvement with over time with long COVID, and that's fantastic, that's great. But it's very clear that is not in everybody. And just because some people show promise and improvement over time doesn't mean that we don't need to take this seriously, because there's still a very big proportion of people who don't show improvement over time and actually regress in some cases. And again, going back to the episodic nature, it's really important that we acknowledge the kind of the fluctuating nature and disabling nature of how long COVID can be. And we also know that repeat infections with COVID can actually actually mitigate and kind of push the kind of the symptom trajectory down as well. So preventing acute infection is really important, and is actually the only way that we can prevent people developing long COVID. What we do know is that the treatment and management strategies, well, there are no treatment strategies at the moment. They're being tested in trials, and I'm leading one of those trials at the moment. But management strategies as well are going to be incredibly complex because of the nature of the pathology and how we can account for that. So we need to determine what the strategies are for each pathology, test them in isolation, and then test them in combination. So the disappointing thing on that is that clinical medical research takes a long time. And as a result of that, it takes time to get to the people who are living this reality right now, and their reality can be quite bleak at times. And we also have to be very honest as clinicians, practitioners, researchers, that there's an awful lot we still don't know. We are only 5 years in to the pandemic. The pandemic still continues, and there's an awful lot that we still need to learn. However, I'm enthused by the fact that we have a lot of global attention and interest in long COVID research, and that's actually allowing effective collaboration. So whilst I've been here in Canada, I've been attending meetings outside of the conference, online and both in person, because it's geographically not too far, to make sure that we can stimulate those collaborations, because that's the only way that we're going to be able to do it. Working together, collaborating effectively is the only way that we're going to find ways forward. Now, this slide, I could talk to this slide for the whole duration of this talk, so I'm going to skip through it, but there's a paper that we've got coming out very soon that will go into each of these pathologies in a lot more detail. And if anybody's interested offline, please do just get in touch. But what I wanted to do here is just show you the sheer extent of the complexity of the pathologies that underpin a long COVID presentation. And what we're trying to do and wanting to get to understand is which of these are most dominant in certain phenotypes of patients and presentations, and how can we implement ways that we can improve them. And obviously the center of this talk is looking around the kind of the respiratory limitations and the interactions on there, but there is a lot going on in the body that could be dysregulated, dysfunctional, not working optimally. We talked about the kind of the integration of the systems earlier, and we all know that one change in one system can have a cascade effect on multiple systems. So we're really trying to get to grips with what the different etiologies and the pathologies are, because when we truly understand, as I mentioned earlier, we can then start to develop interventions. And I congratulate a lot of the research teams around the world for some of the fast-paced work that they're doing. But it's fast-paced and it's needed because the patient's reality is very real for them. So if I look at the lung abnormalities and have a look at the research to these, I'll share the slides with Jenny as well. All of the hyperlinks to the papers are all live, so you can, when you get the slides, you'll be able to click on them and it'll take you straight to the paper, and that have been included in all throughout the talk. But it's very clear that we've got some real issues with kind of the function of the lung and how things are moving through the body. Obviously, the lung is so important. As a respiratory physiologist, it's that easy to say that, but it's true. The primary function is gas exchange and maintaining that kind of exchange of oxygen and carbon dioxide across the blood, and that's an important part of keeping us alive and making sure the cells that we are using throughout life are maintained. And there's a real challenge that we're seeing in terms of the kind of the gas exchange concentrations. There's a few pathologies why we think that might be, but even though spirometry is presenting as normal, we are seeing difficulties and challenges in that kind of alveoli, capillary membrane, suggestions that an inflammatory response might be thickening that membrane, which is making it harder for the oxygen and carbon dioxide to diffuse across and to permeate through that wall into the blood or into the lung, and that's creating challenges as well there. There's also changes in the kind of the interstitial lung properties as well. So there's been lots of kind of imaging related studies that have kind of showed ground glass opacities, reticulations, fiber optic like changes, which really impact the way that the lung can work and the way that it's designed to work. And we know from interstitial lung disease research that that's that simple kind of simple, it's not simple at all, but the kind of the pathology of having that interstitial lung disease effect can really impact the operation or activity of the lung, and that's been demonstrated in long COVID patients. And what I should say is all this literature is related to long COVID that I've shown here. Gas trapping is a really big one. There's been a lot of kind of CT work and MRI work that's showing, trapping of gases and inappropriate movement of the gases in and throughout the lung physiology. That again has massive impacts in terms of how we get the gases where they need to be and where they're supposed to be, and how the body's designed to move them around. And there's kind of this kind of bronchoalveolar involvement and ventilation heterogeneity are causing real issues for patients, and they're heavily linked to some of the breathlessness and the fatigue related symptoms that are out there as well. And what I'm doing at the moment is setting the scene from the pathophysiology, but it's heavily linked to that symptom presentation in and around the respiratory function, and also things like exercise tolerance, which I'll talk about later. Mentioned already persistent inflammation, endothelial dysfunction. There's lots of evidence coming out now about microvascular injury, inappropriate inflammatory response that fluctuates, with engagement with activities, etc. So it creates real opportunity for us to think about how we can, to overcome some of these challenges. And there's I was talking to a lady today actually about this hyperpolarized xenon MRI, which was in my talk before, but it was coincidental that the lady that was involved was in there as well. And talking about, well, they're still within those normal limits clinically, but I take exception to what is clinically normal, because what is normal clinically for a population level sample of data is not normal for that individual. And a drop of 10% in FEV1, FEC, usual respiratory parameters, a drop in 10% is clinically relevant, even if it's within clinically normal changes, because that is 10% of that person's capacity, and we need to take that seriously. So I'm going off on spiel about normative values, and I'm sure we'll come back to that in a moment, but there's big challenges in there. And what we're seeing in kind of the persistent inflammation and endothelial dysfunction is it's not just limited to the lungs, it's system-wide, it's body-wide as well, and has a global impact upon performance and physical function. And again, is heavily linked to the symptom profiles in and around kind of exertion, fatigue, and also general feelings of unwell. If you have an overactive immune system, and that spills out into the various different systems, it's going to have an effect on how your body perceives you to be at that point. And again, this persistent inflammation, these inflammation profiles are so episodic and undulating. They're changing so markedly, so quickly, and sometimes for very little reason. It's almost a bit like being on a roller coaster for a patient. They don't know whether they're going to be at the top, or in a minute they might be at the bottom, or they might be going upside down. And from the work we do with patients, that's certainly how they're feeling at the moment. Also talked about this one. This is probably where my expertise comes in the most, is reduced exercise tolerance and exertional desaturation. As a clinical exercise physiologist, with a focus on respiratory, we're kind of seeing this kind of abnormal, dysfunctional kind of ventilatory response, even to submaximal exercise work. We've been doing a lot of work over the last few years trying to look at, the way that the kind of the perfusion gradients work and the perfusion aspects of respiratory mechanics work, and that's showing some severe impairments. But what we're seeing through some of our work is that as we cascade down the system, we have an impairment at the respiratory system, but also in the cardiovascular, then into the muscular, and it's compounded as we go through the body. And it's really important, because essentially the respiratory system is the first and last line of defense in terms of physical function, because we have that oxygen into the body, and it's responsible for getting the carbon dioxide out. And I'm sure most of the delegates here will know that if that's not operating properly, it's going to have a massive impact on performance and physical function. And we also see high levels of dysfunctional breathing. Respiratory muscle weakness has also been implicated, which we're going to talk about. This table, I'm not going to talk about the table and all the studies that have demonstrated respiratory muscle weakness. Again, I've provided the links, and this will hopefully be a useful resource for anyone who's interested in making the case for looking at respiratory muscle training within research and within their practice. But what I have done is provided a table that kind of gives you an overview of the study, the kind of the measures that have been involved, and the kind of the prevalence, which I think is also really, really important. But I certainly don't want to spend the time talking about it, but I'm just highlighting where the key areas are. And respiratory muscle weakness is not just in long COVID. It's in multiple chronic respiratory conditions, and even in acute infections. A lot of our work pre-pandemic demonstrated acute infection had a massive impact on respiratory muscle performance, respiratory muscle function. The studies that have demonstrated in chronic respiratory conditions, almost kind of like respiratory muscle weakness, but through kind of like ultrasound images, and I'll share some of those with you a little bit later. But what I want to do with this slide is just generate that conversation that respiratory muscle weakness in long COVID is a real consideration, and something that we need to be taking really importantly. Like in the UK at the moment, I'm working with patients who are, they've come through as trials. We've shown and demonstrated respiratory muscle weakness, and they go to their medics and they go to their GPs, they go to their clinics, and they're like, oh, we don't test that here. We test lung function. I'm like, well, okay, but the respiratory the respiratory system is not just about flow and air into and out of the lungs. It's around the whole unit, it's around the whole system. And the respiratory muscles are an imperative part of that process of getting flow in and out, not just the kind of the airway dynamics. And it's a really important conversation that we need to be aware of, because we're seeing an increased prevalence of people coming in with poor respiratory muscle mechanics. And that's where we create an opportunity to develop interventions that we can implement to support people in kind of, bringing forward those kind of positive changes. And I have to link that back to my pre-pandemic, pre-clinical work, where we were demonstrating the physiological impact of making these muscles better and building their capacity, which I'll share as we progress through the slides. So if I take this back to the kind of the respiratory muscle physiology and the mechanics and why that's important, the respiratory muscles have a massively important role in governing the global physiologic response to what's happening internally inside the body and what's happening outside the body. And from a respiratory muscle perspective, they're highly rich in group 3 and 4 muscle afferents, which tell us about the chemical composition of the body, the mechanical composition of what's happening. And it's this constant feedback loop between the afferents in the central nervous system and the efferent responses that happen as a result of that. And the response to those kind of group 3 and 4 afferent activity is really centered around kind of modulating the blood supply that goes to the respiratory muscles. The diaphragm is heavily enriched with blood vessels. If we start to detect an increase in breathing pattern, the body is very good and intricately increasing the amount of blood that can be given to the diaphragm to maintain ventilation. And essentially, without ventilation, none of us are here. So it knows and it can protect and can sustain that kind of performance of the respiratory muscle mechanics. So they play a hugely important role, and we can break that down to the obligatory muscles, which is your diaphragm, which is essentially every breath you take, the diaphragm is involved, but also the accessory muscles. So we're bringing in the muscles in and around the neck and the chest wall, the primary role of assisting with ventilation when required. But we're seeing patients in long COVID who specifically, even at rest, are using this accessory musculature. So it's not designed to be used at rest, but they're using it because they need to be able to sustain ventilation, and they're having to bring these muscles in to support with that process. And that has an impact on the global physiologic response, because the body will prioritize ventilation over everything else for the reason that we outlined earlier. The respiratory muscles are essentially, they are skeletal muscles. Okay, if you look at the morphology, you look at the breakdown of the kind of the muscle fiber distribution. They're essentially skeletal muscles. The only slight difference is the neurological component, and that's essential for the diaphragm, because if I had to think about breathing, I would probably forget. I'm sure we all would at times. So it has this neural control which can take over when we do forget to do the important things, and it also has that neural ability is really important to make sure that we can bring those accessory muscles in when required. So when we see a change in ventilation or demand for ventilation, we can implement and instigate these accessory muscles just to support and to kind of alleviate that and kind of maintain that homeostatic balance to a point as well. And essentially, we have this intricate and very refined reflex mechanism that is constantly in contact with the musculature to determine what's happening and what appropriate response is. So any of you in the audience that respiratory reminded know that the change in tidal volume and minute ventilation and breathing frequency is a very intricate process. It's very optimized relative to demand. To the demand, and essentially because the body hates using energy, so it tries to do it in the most efficient way possible, making those changes. And it's a constantly changing process that's governed by that feedback, feed forward mechanism that we referred to earlier. And respiratory muscle capacity is a really important part here. I'm going to show a picture from a paper I published with Richard Severin, who's a very renowned respiratory physiologist in the States, and very excellent collaborator. I love working with him. His energy is infectious. It's brilliant, especially when you're on a different time zone. It's good, and I can't just blame that on the coffee. But what I'm going to show here is this picture that we published in 22, and that was referring to the kind of the role of respiratory muscle screening within kind of COVID services and long COVID services. And essentially what we're showing here is that if your respiratory muscle capacity, and by that we're looking at this green box on the left-hand side of the panel, the right bar, the big green box, if your capacity is high, and your worker breathing is low, you have this extra capacity to actually function those muscles, and you can increase the worker breathing before it becomes problematic, because your body knows that it can tap into that additional resource when it's required. However, on the right hand side of the image, if your worker breathing and your capacity are equal, your body's going to know that it's working close to its limits, and then as a result of that, it's going to have a very different physiologic response to that situation. And on the right hand side, what we're looking at there is very symptomatic of a lot of chronic respiratory conditions, and inclusive of long COVID, because what's happening is that the muscles are working very close to their capacity. The body knows that there isn't much left in the tank, and as a result of that, it will govern the physiologic response. It will have different impact on that blood distribution, the blood flow distribution. It will be working harder, and it will know, the central systems will know, and it will detect that, and it will prevent kind of going into this catastrophe of working too hard. So as I mentioned, the body will preserve ventilatory function. That makes complete sense for a lot of reasons. And it was governed by a concept called the respiratory muscle metaboreflex, which was Jerome Dempsey's work in the 80s, an absolute hero, and kind of understanding the mechanics of the diaphragm, respiratory muscle fatigue, and the cascade of the research that followed has been phenomenal. And essentially, it has that consequence. If we breach that capacity, if we work the muscles too hard, that has a real function. And we're not talking about high-end levels of performance when we're in the clinical context. We might be talking about activities of daily life and general daily activities, and creates a real challenge for us to think about. Like I say, that's what I was just saying. In clinical conditions, there's a real consequence that can happen sooner. So essentially what I've done so far is create this opportunity to think about, well, we have this we have this challenge clinically. The pathology of respiratory muscle weakness creates a big issue, and hopefully I've set the scene in terms of the implications that can have for human performance and physical function. This is a figure that's taken from a paper that was probably heart and soul of my PhD a long time ago, but kind of just has a look at the different ways in which we can stress the respiratory muscles. And that's really important, because I go back to the context of what I said earlier about they are skeletal muscles. If you put an external load onto a skeletal muscle consistently and over a period of time, it will adapt, and it adapts using those general training principles. So this study from Lee Romer and Alison McConnell was quite landmark in the fact that they looked at the different ways that you could test and stress the respiratory musculature using high pressure, low pressure, low flow, high pressure, the different mechanisms of doing that. And I've just synthesized it. So, high pressure, low flow is characteristically known as flow resistive loading. Essentially, it's a bit like breathing through a straw. There's no kind of pressure in terms of external load. You're not breathing against a resistance, but you're breathing through a smaller aperture, and it changes the pressure concentration that's required to get the air in. You have to work a bit harder to get that in. And over a period of 6 weeks, they saw changes in the strength, but not so much in the endurance of the respiratory musculature. And then you've got voluntary ischemic hypnea, which is slightly different, the other way around. So you've got low pressure, high flow, and they saw some changes in the strength, marginal, not statistically significant, but statistical significance in the endurance. In my opinion, probably both of these are quite difficult to do in patients with long COVID, and I'll come to that specifically in a moment. And then we've got pressure threshold loading, which, as you can see from the image, and they're supposed to be, there it is, I forgot to animate it properly, apologies, where they saw changes in strength and endurance of the muscles, and then they also combined it against a control group. What I'm getting at here is there's multiple different methodologies, and it really becomes dependent on what it is that you're looking for, and also the appropriateness of the groups that you're working with. And I don't know what your groups will be and what your presentation will be, but there's considerations that need to be there. But all of them show benefits in terms of improving respiratory muscle function, whether that be in strength, whether that be endurance, or whether that be in both. What I'm going to do is just kind of talk about some of the structural changes. So essentially, training of the inspiratory muscles, training those muscles that are responsible for inspiring air into the body, is essentially strength training, as I've already mentioned. So imposing a load on the diaphragm will result in structural changes to the diaphragmatic function, and that changes the structure in a variety of different ways. So we get an increase in the cross-sectional area of the muscle, so we make the muscle bigger. And for those of you that have got an insight into kind of strength training it's kind of like that hypertrophic response. So the muscle knows and adapts to the fact that we're putting it under pressure. The body doesn't like being put under strain and stress, so it adapts and it increases that. And we can show this from some of the work from Downey's group, again, quite early on, but still very relevant, even now, almost 19 years later. The image on the left shows a cross-sectional image of a diaphragm taken from somebody with, this was a performance setting actually, but the average was about 2.9 millimeters in thickness. Post-intervention increased to nearly 4 millimeters of thickness. So big changes in the structure of the diaphragm and the presentation of the diaphragm that can come as a result of it, and that then increases the capacity that I referred to on the previous image, which was around the green bar. I'm doing that because we're increasing the capacity of the muscle, so we're increasing the resistance to fatigue, we're increasing the power generating capacity, and essentially that should have a big impact. We also know that respiratory muscle techniques are really important in refining that neural control. Any part of strength training research, again, for those of you that are interested in that, will know that the first parts of any increase in performance are predominantly neural focused, refining that connection between the central nervous and the peripheral systems, making that more efficient, making that more effective. Again, efficiency becomes really key in that neural aspect because the body doesn't want to waste that energy. And there's been some studies that have shown changes in the muscle fiber composition and increase in mitochondrial density, which is important again for that kind of aerobic capacity and potential. So there's lots of research that has shown the benefits and efficacy of using inspiratory muscle training in different clinical populations. And again, this was a lot of my work pre-intervention. I was actually catching up with Jenny just before the start of the webinar to talk about some of those. And I didn't do this because I didn't know Jenny, but you talked about weaning, before as well. So I'm really glad that that's in there. But it has lots of application clinically and lots of relevance and lots of research that kind of supports it. And my pre-pandemic research was looking at those people admitted to hospital with community-acquired pneumonia and whether this could be an adjunct therapy that they could go home with through their recovery. And we actually spend quite a lot of time with our patient groups determining, whether people who are going home still poorly are actually capable and being able to go through, these training processes. And we determined through probably a 6 to 8 month period with our patient groups that they weren't able to do that. And we needed to think about different ways in which we could build capacity and build also confidence to try these interventions. And we had to work with them. And it actually took about 18 months for us to refine and test and pilot some of the work that we did. But what we did was kind of, change things, and don't be afraid to try things and change things and make things, better for patients if it can have an impact on their performance. So we actually included a 2-week habituation period rather than, going straight into the traditional 6 weeks of training. And then we worked on an incremental basis where the load was maintained at the optimum levels, which is kind of like, normally about 50% of the maximum inspiratory pressure, but increase the load. So being progressive in the load and kind of giving them the confidence to do that. So we started with 10 training breaths per session in the first week. Then we progressed that towards 20 and then over towards 30. But what we also did was make sure that we adjust the training load relative to their daily performance. So when you're overloading a muscle and you're in a kind of a state of kind of, in a health challenge like an infection, your performance isn't the same. It fluctuates. And we know that if you train a muscle too hard, it won't adapt. And if you don't train it enough, it doesn't adapt. So we had to be adjusting that load on a daily basis to make sure that we could give them or kind of provide them with an opportunity where they could thrive in that training aspect. And it was actually really good. The protocol that we developed, we tested in the study published there. It was really safe, it was well tolerated, and was actually effective. And this was the feasibility trial that we finished in 2019 that was going forward to the planned trial in 2020, which I've already alluded to didn't happen. But I know the clinical team are still desperate for me to follow up with that. And I'm talking about a technique and a method. Inspiratory muscle training has been used in long COVID. Melita McNary at Swansea University in the UK was the first study to kind of show changes in respiratory muscle performance. This was in that kind of 9-month period after acute infection. They saw changes in breathlessness, respiratory muscle strength, and estimated aerobic fitness. And estimated was at the time when it was actually quite difficult to get in labs and do physical tests in the UK. That wasn't permitted for quite some time, but it was a really innovative trial and really demonstrated the kind of the benefits and the importance. But there's been a kind of, a subsequent number of studies that have really kind of come forward and demonstrated the benefits. And we're looking here at kind of, using this against usual care. Does this offer benefits and offer an opportunity? Yes, there's kind of been shown there. So, some of the follow-up work has shown changes in quality of life, in symptom profile, in aerobic capacity, and that's linked in some of the kind of the later work by the Del Coral groups, because what they've done is they've shown that these changes in respiratory muscle strength and performance have an impact on lower limb strength. Now, they didn't train lower limbs, but there was an impact of taking away, the strain, and the respiratory system had a more peripheral response. And we can link that then to things like in changed quality of life and functional status, because people are able to do more because there's less competition between the systems that is happening. And as we've alluded to throughout the talk, it will favor the respiratory musculature. So there's positive evidence, but the use of inspiratory muscle training is not implemented as a management strategy widespread. I'm not quite sure why. The evidence pre-pandemic and even post-pandemic is really positive, but we kind of need to get this in as a method, as a management strategy, especially for people with long COVID, whilst they wait for those effective treatment trials and the trials of different candidate treatments and kind of the individual and the combination therapies. That's going to take, it could be a decade before we kind of get to having an established treatment pathway. And I hope it's sooner, but the reality of clinical research is it takes a long time. So we do need to prioritize, and we do need to make sure that we have opportunities for people to engage in management strategies that can alleviate some of those symptoms that are massively impairing their daily activities and their daily life, whilst we wait for those treatments to come through. And even when those treatment comes through, we're going to have a widespread population of people who will need to be engaging with rehabilitation, and that rehabilitation needs to be system across the different systems. It needs to be interdisciplinary, and it needs to be integrated to address the bigger kind of clinical picture and the clinical presentation that we're seeing on a daily basis at the moment. So, how do we apply inspiratory muscle training in long COVID? I think if I speak openly, we can see those structural and morphological alterations that can have, a big impact on the symptom presentation and make people feel a little bit better. Consequently, as a result of feeling better, people will do more. So we'll be able to, address some of the symptoms like fatigue and breathlessness, which are, prominent symptoms in long COVID. But we're going to be able to try and, alleviate that. And as a consequence of alleviating those symptoms, people will do more. And with any intervention, it's very prudent to say that the intervention will not work in absolutely everybody. We need to be able to, be okay with, trying different things and implementing different things, but also to know when it isn't going to work or where it isn't relevant and where it isn't appropriate. Because inspiratory muscle training could, provide as a viable management strategy, but there's lots of considerations that we need to wrap around it. And especially in the context of long COVID, we do need to be cautious in how we work with patients and how we recommend this as an intervention. Because one of the big challenges that we're seeing at the moment is post-exertional malaise, post-exertional symptom exacerbation. So even nominal engagement in external loads, whether it be physical, cognitive, emotional, can trigger a worsening of symptoms that can last for days, weeks, and potentially even months, and has even led to hospitalizations. And it's currently reported in around 50% of people with long COVID, so half of them, but it has been reported in some of the prevalence literature to be much higher. But I think the consensus is that it's in and around that 50%. So if we work somebody too hard, or we pose an external load that's too hard, it could result in a worsening of symptoms or a crash, as patients refer to it. But some of the methodologies that I referred to earlier have they work at suboptimal loads, so they're not working muscles at 100% of their capacity. Even traditional strength training literature assumes that you need to be working in around that 60 to 80% to get strength adaptations. It's actually been demonstrated in a lot of inspiratory muscle training literature that positive change in muscle dynamics and muscle function can occur at lows as low as 50% of the muscles function. So there is an opportunity to do there. We just need to be very careful to make sure that we to be aware of post-exertional malaise. And this is an image that I created with one of our patient representatives to explain what post-exertional malaise is. And I have to credit Lindsay Skipper for supporting me with this, because it's a fantastic infographic that just tells you what post-exertional malaise is and what can cause it, and what the kind of the impacts are. And this is currently an image that we've got under review in one of our papers, the pathophysiology paper that I referred to earlier, actually, as just an explanation. And it doesn't mean that we can't engage in these exercises. We just have to be cautious to make sure that we know where it's appropriate. People that are at high risk of post-exertional malaise probably are more likely to have a worsening response. So I'm not saying that we shouldn't do it, and we just need to be very cautious and make sure we screen people to make sure that we understand the kind of the impacts of what we're doing. And there's possibly a reason for that, which I'll kind of come to in a moment. And like I was saying earlier, though, that most inspiratory muscle training protocols are traditionally submaximal, so they don't go above that, kind of typically above that. There are some protocols that will go to kind of like 60%, but a lot of them are lower than that and have demonstrated benefits to, intensity is much lower than that. The challenge we've got in long COVID is we just don't know where that, in people that have got PEM, this is only for those that PEM. If you don't have PEM, fine, there's no reason why you shouldn't be doing this. But when people do have PEM, whether it be moderate or severe, we just don't know where the tolerance limit is. And it's probably most likely changeable, which goes back to that within day, between day variability of symptoms and performance. So we just need to be okay with, like, working with patients and communicating with patients to make sure that, we're doing things that are safe. And this is where changing the intensity within a day relative to how they're feeling and how they're performing in this kind of titrated response actually could, provide a real positive benefit, because it will increase the adherence, it will increase the benefits, but it will recognize when we need to take a foot off a little bit. And that goes back to my, career before this one and the one before that, probably in elite sport. And it's just knowing when to push, when not to push, and when to move back. And it's just the consequences, in my opinion, now is that it's more severe in terms of a patient. But I'm going to show that on the next slide anyway. So reduced thresholds of tolerance. They've talked about this, and this kind of threshold of tolerance, this variability in that. And I've only got 2 slides left, so kind of bring this to a head quite nicely. Is this reduced threshold of tolerance? Everyone has a tolerance limit to where they are going to achieve a training response, and if you go far too past that kind of intensity, or you're going to go into a state of overtraining, and your body doesn't like that. You don't actually adapt positively in a state of overtraining, and it just has a negative impact on your bodily function. And anybody will know that if you're physically active and you go to the gym and you try something that's new, you will notice that the next day. Or if you haven't been to the gym for a while and you go back to your routine and you don't adapt the level, you will notice that through some form of trying to move the next day, and you kind of get a reminder that you probably did a little bit too much. And that, that's not a positive aspect. But in patients with long COVID, what we're seeing is that some aspects and some tasks, so things like taking a shower and walking, maybe things that we take for days, can have a negative impact. And we use the battery philosophy. We've all got mobile phones. You put it on charge probably before you go to bed at night. You take it off charge in the morning. Your battery's at 100%. It's the whole principle of daily activity. Is you go through the day, you use your battery, and as a result, by the end of the day, it becomes depleted. And that's the same for how we, exist through days. So having, but in long COVID, we're seeing people have smaller batteries, or activities that they do use more of the battery. And it's just a good analogy of how we kind of spell it out for people. And threshold testing, is a really common physiological assessment. It gives us an understanding of how well things are working. And it can actually help us to actually document and to create an understanding of where this threshold and where this PEM response is, so that we can mitigate against it. And that allows us to kind of quantify where we are, what we can do as a result of it, and also to demonstrate the changes that we've kind of seen. And the key thing here is working with the individual and not trying to apply broad brush approaches to a situation. Everybody is different. Everybody has, a different presentation. Everyone has a kind of a different threshold for how we're going to change it, and we need to work to that individuality and to recognise it, to support it, and to enforce that. Working with individuals, not collectives. So I'm just going to show this slide very, very quickly before I get to my conclusion slide. If I show this kind of this picture here, this is the kind of the general principles of overtraining in a healthy individual. And I caveat healthy because I don't know what healthy is anymore with the world we live in at the moment. Is there such a thing? I don't know. But we have this kind of safe zone where we can undertake activities of daily life. It doesn't necessarily create any real challenges for us. And then we start to kind of impose external loads, kind of like going to the gym or working really hard. Essentially, we go into this functional overreaching. That's where the adaptation occurs. That's where we stress the systems. The systems respond by going, okay, I don't want to feel like that again, so I'm going to get better. If we push a little bit harder, we go into overreaching, and then your kind of body knows that, don't really like you doing that. And if we push harder still, you go into the danger zone, and that's that kind of that overtraining aspect. And they're the general principles of exercise training that have been long and standing. That's not new science. But the challenge that we're seeing in people with long COVID is actually that the challenge might be that activities of daily life, or things that we would consider to be normal activities, again, caveating, I don't know what normal is that those kind of, we go much quicker into that kind of functional overreaching for nominal intensities or activities that we might necessarily take for granted. And this is not it's not a figure that I'm going to show in terms of wanting to put you off, because I think, and go back to my point in wanting to say, it's just being able to recognize how we implement and integrate activities such as respiratory muscle training into that context for the benefits that we've achieved. The benefits are still there to be had. It just requires careful consideration and implementation, and comes back to that individuality and that individual nature of what that might look like in practice. Because essentially what we might see is just a smaller safe zone, and we might be going into functional overreaching earlier, and getting into the danger zone is much easier. But again, I don't want to perturb anyone from thinking that this is a thing, because respiratory muscle training certainly has a part as a management strategy. What I'm trying to do is give you balance, to give you consideration for what the things that you need to consider are, to make sure that we can implement this effectively. And there's certainly some research that I'm going to pose in my very final slide, just looking at my watch one more time, to kind of make sure we do this, because based on what we know in the pathophysiology of long COVID and where we are with the research, it offers potential. It really does. It offers potential to address respiratory muscle weakness, which has a whole cascading impact on the kind of the physiology and the global physiologic presentation in terms of performance, functional status, and symptoms. And essentially, it has the opportunity to improve respiratory muscle architecture and the efficiency of those muscles that then work, because we can refine the processes and the ways that they work, and they can work better and more optimally. And there is evidence that shows that, from the pre-pandemic research, but also to the research that's happened since the pandemic, because we're still in it. But there's kind of some areas and research, and I always like to finish a talk by posing questions that the audience can then go away and answer to move the needle, which is another phrase I like to use, is about how we advance the understanding and advance the knowledge. And if anyone's interested in doing this with us, or wants some support and guidance, I'm more than happy to kind of do that, because essentially what we kind of need to look at is that safety, tolerability. Acceptability is a massive thing. Acceptability is very underrated as a concept of developing and implementing trials. If patients aren't going to do it, they're not going to do it. So we have to find ways to test the acceptability. I do believe that it is. We've done it in the pre-COVID work, and we had a very high level of adherence and acceptability. People loved it. People went and bought their own devices as a result of it. I'm not here as a marketing person. I'm not here to sell things. That's not me at all. But people did kind of really get onto it and demonstrate the impacts. And I haven't got time for it today, but one of my most powerful stories was somebody who took part in one of our trials. I saw them a few years later. I didn't recognize them, and I put my hands up, but they recognized me, and we had a very long chat, and it was actually quite emotional, if I'm quite honest. But that's the impact that we can have when we're working with these people. But what I would encourage you to do is do that by using co-created approaches. Bring the patients into helping you design how this looks, how this works, how this feels, and how we test the kind of the effectiveness of that. Because you're only going to get acceptability if you build an intervention and develop an intervention with patients. I think we've all kind of again, I'm not sure the audience has background and kind of working scenarios, but if you went to a patient or to a participant or somebody and just kind of went, I need you to follow this for the next 12 weeks, they'd probably do it for the first couple of weeks and then get bored. If they're involved in the development process, then they're much likely to be more engaged with that. And we should never do things for people, we should do things with people. And that's another one of our philosophies for research. And then test the efficacy. Get out there and let's do it. Let's work it out. Let's show the benefits there and use it against standard care models. Because if we can do that and we can show the efficacy, we can make sure that respiratory muscle screening and function is part of clinical care pathway, so that we can identify respiratory muscle weakness, and then we have an intervention that's ready to go for us to roll out. And I can't believe I've just finished at 10:02, which is exactly what I was aiming for. So thank you so much for listening. I'm happy I'll stop sharing in a moment and we'll take any questions. But yeah, I hope that was useful. And my contact details are there for anyone that wants to reach out. Thank you.
Dr. Thank you so much for that. I think it was very useful. And as we were chatting before, I think a lot of patients with long COVID are feeling forgotten at this time. I love the idea of co-creating a treatment and involving them. And I think this knowledge will be very useful to the clinicians here, and hopefully they can take that and apply that in their setting. So we appreciate you. I have a few questions from the audience. We have a few minutes left. So one is, has airflow and resistance in the nasal passages been measured via rhinomanometry?
Oh, fantastic question. Oh, you didn't start with the easy ones, did you? So we've done some work internally, kind of, my computer's doing something funny again. Can you still hear me?
I can hear you. Yes.
It did this before, didn't it? It just kind of did something random.
Yeah, we lost you before, but you're still here.
I'm not touching anything, I promise.
We're good. We're okay.
So, we did some work kind of looking at the kind of the nasal, the cavity, and whether that becomes impaired, because we do see inflammation through there as a result of the direct infection that can cause an insult in terms of the function and the pathology of that. I don't have the data off the top of my head, but if you want to send me that through, I'm more than happy to populate a response and share it back to the audience and the people that are asking the questions. So
yeah, I think it's very interesting. We have a sleep neurologist that we work with, and he was anecdotally sharing that he actually does rhinomanometry with his patients and has seen a big change with the application of RMST.
Yeah, one of the big things that we're seeing in patients as well is nasal breathing, just to regulate autonomic function and autonomic tone, is a good way of quelling the kind of the breathless response. Now, that's more of an immediate response rather than a kind of an everyday response. You do that in reaction to something, or feeling potentially upregulated in that kind of vagal tone. So it's widely used in clinics in the UK as a kind of to reset the autonomic function. But it's a kind of a short-term aspect. If we put it in the context of asthma, it's like using your blue inhaler. Is that the case? Right? Yeah. But it's a short acting. It gives you an immediate relief, but it isn't a kind of a longer term thing. Where if we can implement the respiratory muscle training and we can improve those airflow dynamics, you might get a change that's more substantive. But I'd have to go back into the evidence to have a look.
Yeah. And then our next question is from a speech therapist who says, I typically work with expiratory muscle strength training, which is very big in the speech world because of the research behind that for dysphagia. And the Del Correll et al. 2022 study that you had looked at inspiratory and expiratory. Do you feel there's a significant difference between use of these two modalities in these populations?
Yes, there are. Which one is best is a very different question. I'll try and unpick that. I think when you look at the inspiratory and expiratory muscles, they are very different in terms of the function and the way and the kind of the size and the magnitude of those. I think a lot of respiratory muscle weakness tends to be on the inspiratory muscles. The coordination tends to be on the expiratory. So having that kind of refined coordination on an expiratory muscle has a big impact in terms of the airflow dynamics and the ability, which is where the dysphagia comes in that you mentioned. Whereas the inspiratory is more the kind of the actual muscles themselves being kind of demonstrating that weakness or that kind of reduced architecture. So yeah, it's a great question. I think I wouldn't put both of them together. as an intervention. I think that would be too much. What I
Mhm.
would do is I would work out which is going to offer the most benefit first, and then offer them maybe concurrently, but in a staggered format would probably be my recommendation.
And I think it's nice that you brought up how this could be such an interdisciplinary sort of intervention, and we should all kind of be looking for the red flags and getting together and talking about this because I think healthcare can, in larger systems especially, can be very siloed.
Hmm.
So giving people the opportunity to have that conversation is very
Yeah.
key to the rehabilitation of a person, looking at them as a whole person.
Absolutely, and I'm really glad and I see this a lot in the States, less so in the UK.
Mhm.
But in the States, it's this phrasing around interdisciplinary. In the UK, we tend to use multidisciplinary, and there is a very distinct difference between the two. One of which essentially is just working in silos, but putting notes on a system that someone might read. It doesn't. It forgets the whole global picture of what a presentation might be, and the impact that you can have on the other systems by improving respiratory function can be really profound on the cardiovascular muscular systems. And we cannot be ignorant. And so, I've been at this conference in Canada for the last couple of days. Everybody uses the word interdisciplinary. And I published a paper a few years ago with one of our clinicians in the UK going, we need to stop talking about multidisciplinary and we need to talk interdisciplinary. So I'm delighted that, that's the terminology that's used over here. And that absolutely needs to be the case. The only way we can truly resolve people's clinical presentations, whatever the condition, is if we work together and bring in the expertise. So 100% agree with that.
Yeah, likewise. There's always something to learn from your, I think, fellow clinicians. You have a comment from Dr. Severin, who is in our audience today.
Oh, yeah, good
Well
man.
done.
Good man. Oh, I
Cheers,
love
mate.
Rich.
Yeah,
Huge name. Great guy. Doing great things. So keep being awesome, Rich.
yes, agree. We are deeply grateful to Dr. Severin for introducing us to you.
He
So,
did. Yeah. That's
yes,
where
we
that comes
appreciate
from.
both of you.
Hopefully, I haven't let him down.
You know, I think we're all very impressed. Um, we appreciate you so much, and let's see. I think we have one more question, then we can wrap up. In your studies or experience, what do you use to judge patient threshold as well as effort to determine and adjust training loads and to find sweet spots and avoid PEM or overtraining?
Oh, fantastic question. These questions are brilliant. Yeah, absolutely. Yeah, I think we have to have this adaptive approach. I don't think we can go into a condition like long COVID where we know that it's episodic and undulating, assuming that 50% on day one is going to be exactly the same on day 7, day 10, day 2, potentially. There are devices and technologies out there that will allow you to adjust the load relative to the performance and the function on that day. And that's really important. And it was, again, a question that we were asking pre-pandemic was around, you get this accumulation of fatigue effect over the source of over consecutive days. And we were actually, this was in the applied world, we were talking about it in the context of swimming, because the the kind of the aquatic pressures change the way the muscles work. They also have high training loads. Essentially the respiratory muscles are very, very tired, get very tired because they're under load constantly. So how do we change that? But bring that back to the context of clinical. That's happening without the training aspect. So what we need to do is to refine that training load, to find those sweet spots, which I think was the phrase that was used in the question, but do that relative to the person, relative to the individual, relative to their performance and their function on one day. I think by doing that, you will actually get a better training response, and you'll certainly get better adherence because you're not pushing people to a point where doing the training feels hard. Doing training is hard. It has to be an adaptive response, otherwise there's no point in doing it. But there is, as I showed through the kind of the image around the overreach and the overtraining and the danger zone, the further you get to the danger zone, the less response you get anyway. So knowing when to bring things back and knowing when to put things forward is huge part of just fundamental physiology of how we stress systems.
Yeah, and I think your most important feedback is coming from your patient themselves in
Oh,
these
yeah,
situations.
they are the people. They tell you how they feel, and they will tell you. They don't hold back, as you'll know from your own clinical work.
Well,
Uh,
yeah. And we have clinicians who will write into us and ask, well, my patient can't do the exact protocol because we have a recommended protocol. And my response
Amazing.
is always, you have to listen to your patient because it is a general protocol for a reason, but it won't apply to everyone, and absolutely needs to be adjusted for each patient based on what they can tolerate and what is of benefit to them.
Absolutely. And, just to follow on from that comment there, what's also really important is to, if you look at respiratory muscle training literature over a 6-week protocol, you might expect a 30% increase in respiratory muscle strength. That's a holistic value that's been governed from research. But celebrate the wins. If someone's demonstrating an 8% or a 10% improvement, that is still huge and could be having a huge impact on their, their function and the performance. So yeah, work with the individual, find out what makes them tick, get them involved in the design and implementation, and you will see better engagement, but potentially better outcomes. And it's the only way that we can think about implementing management strategies that are going to be long-standing, scalable, and successful.
Yes, patients first.
Patients always first.
Yeah, I feel like we could chat all evening, but we're going to wrap up here. We thank you so much. For those of you in the audience who would like a certificate of attendance or the slides as you kindly shared, please email me. My email is jenny@emst150.com. And there was somebody in the audience who was interested in some of the research and things I said regarding sleep apnea. So please feel free to reach out to me. I can very happily share that with you. Thank you very much again. Have a good
Thank
evening.
you for having me.
Enjoy your time in Canada.
I will. Thank you.
Take,
Thanks, everybody.
thank you.